All right, so it's recording now. So we talked about the COX-1 and COX-2, and what they do in the body. All right, so what you need to know, you do need to know about the COX inhibitors, like aspirin and ibuprofen. This is the NSAID class, and what it does, we talked about how it kind of like protects the COX-1 and COX-2. They're enzymes that creates prostaglandin, and it helps protect your stomach and kidney, right? And with the stomach, with your lining, to make sure that that it is protected from the acid, and then for your kidney with the perfusion. So with the NSAIDs, it does prohibit, like it kind of inhibits those things. So that's why they're called COX inhibitors, because it kind of keeps those enzymes from creating prostaglandin. Does that make sense? So all the things that those prostaglandins are doing in your body, when you start taking NSAIDs, it kind of inhibits some of that. And then if you take it prolonged, like that's why you'll see all those side effects longer with like possible stomach ulcers or bleeding, because you're constantly like increasing the chances of getting a side effect or an adverse side effect. Okay. But you do need to know those. You need to know the NSAIDs. You need to know like aspirin, like the nursing considerations for these drugs, right? Specific things we talked about. Do you remember what we talked about with aspirin?
It prevents the platelets from sticking together.
Right.
And
And
it
what's
harms
what's
children.
nursing? Go ahead.
It said it harms children, so you can't give like anybody 18 and under aspirin.
Why is that? 19 and under.
Or 19 under. I forgot the term. It starts with a K.
Ray's syndrome?
Or something like that.
Yep.
Right?
It is Ray's syndrome. And what's Ray's syndrome consist of?
It's the
What is
fluid
it?
buildup in the brain. Or something like that. Or is that what
Yeah.
babies?
That crosses the blood-brain barrier or
Oh,
something
yeah.
like that? I don't know.
So with Ray's syndrome, there's two things we're looking at. Number one is liver damage, and then number two, it creates swelling in the brain.
Okay.
So when you have swelling in the brain, we talked about the skull in class, whoever was in my cohort, and how the brain only fits certain amounts of things, which is your brain, blood, and the cerebrospinal fluid. So anything that affects that could increase the pressure in the brain, right? So that's why it's so dangerous, because when you have increased pressure in your brain, it can cause seizures, it could cause coma, it could cause death. So anyone who's 19 and under, we don't want to give them any aspirin, okay? Right. What else do you guys want to know about?
Professor, do we need to know the category of the drugs? Like acetaminophen is category B and on and so forth?
Not to that point, no. You just need to know what acetaminophen is, and what's the potential side effects, what does it treat? Also that, it is different than an NSAID, right? What's the difference between the NSAID and acetaminophen in particular?
One goes to the liver, one goes to the kidneys.
It doesn't have anti-inflammatory effects, acetaminophen.
Yep.
Thank you.
Yep. And acetaminophen basically, it works more with the central nervous system. So with that being said, like it doesn't have, like you said, it doesn't have any anti-inflammatory, but it's the CNS that's being affected by it, or where it works. So it does work as an analgesic. So it does help with pain, and then it works with the fever, but no anti-inflammatory. Okay.
Wait, so acetaminophen isn't an NSAID, it's an analgesic or whatever?
So it's a non-opioid analgesic, which also, I mean, basically, okay, I'm gonna break it down. So the NSAIDs are also non-opioid analgesics, so that's why it helps with pain. It's non-steroidal, anti-inflammatory, and antipyretic. The only difference is with Tylenol, you take out the non-steroidal anti-inflammatory part. So it does the other things. It works with fever and it works with pain, but it doesn't work with inflammation at all.
Okay.
Because it only works in the central nervous system. So that's the main difference with that.
Did you touch on? Oh, go ahead. Sorry.
No, you go ahead.
Since it works with the central nervous system, how I remember there's something on neuropathic pain and what is given as a like a helper drug. Would acetaminophen be one of those helper drugs given for neuropathic pain?
So the helper drug is the adjuvant drug that you're talking
Adjuvant.
about. That would be like the gabapentin is the helper drug. So that the gabapentin would help with like, let's say you have like really bad one like neuropathic pain, and they'll take like opioids for it. The gabapentin will help with that because opioids really are terrible for that. Like it doesn't work as well with neuropathic. But with Tylenol, I mean, yeah, I can see it, but normally when they're giving gabapentin, like for neuropathic pain, it's usually like strictly for that, but they might get Tylenol. That's not a bad thought process.
Could we possibly like, like underneath the module thing, like her exam one study guide, could we possibly just like go through like roughly like the couple topics that are on that so that we can just make sure like we're in the know and we have the
Absolutely.
right info?
Let's see. Do you guys have it pulled up?
Yeah, I do. There's like we have like the one stuff that we went through in the intro, which is just like the terms and stuff. And then the second section is like the specific drugs that she wants us to know for this exam.
Okay, let me see. Assignments, modules. So if you go to module one, honestly, everything that you guys need to know on the test are literally in your content outline. So yeah, pharmacodynamics, pharmacokinetics, yeah, all like what section did you want to do? There's a lot on here.
I think it's just mainly like if like we could just like, for example, like aspirin, like what is like this and this and this and about aspirin. Not saying we need to go over that one again, but like you know what I'm saying, just to make sure we all have the right information and we're studying the correct things.
Absolutely. I believe we did upload a few things for you guys as well for like a list of medications. Did you guys see that?
Yeah,
Let me see.
because we have like the opioids, aspirin, prednisone, oxycodone, morphine, naloxone,
Right.
antihistamine, PCAs, like that kind of stuff.
Okay, okay, so I'm pulling out the one for the drug for inflammation and fever. So we talked about the nonsteroidals, the NSAIDs like aspirin, right? This specific, and then all these medications are nonsteroidals. We talked about Celebrex already. So we do need to know that that's the only one that's the selective COX-2, right? So the corticosteroids with prednisone, we need to know about prednisone for sure. With that, let me pull up my stuff. Like a gazillion windows. Hold on, okay? um Corticosteroids. So just know like the nursing consideration for that, like knowing that it might increase your blood glucose levels, right? So the corticosteroids or glucocorticoids. Your body does make this itself. So that's the reason why we kind of have to taper it down, because if we give you corticosteroids, what ends up happening is your body stops making it while you're on it, because we're kind of providing that. That's why we have to taper it down so your body starts making it again. So by the time you take your last dose, your body's pretty much making itself like what it needs to do. If we don't taper it down, what ends up happening is your body can go into an adrenal crisis. And what it does is just, like it's just a complication that affects a lot. It's a hormone that can affect a lot of your body, but just know that you have to taper it down. It is very, so when we talk about NSAIDs, it's non-steroidal. Corticosteroids are steroids. It's steroidal, right? So it's a little bit more stronger. This will need a prescription. This is not something you get like over the counter. I know a lot of people like go to Mexico to try to get these medications, right? Because they'll give them whatever they want. But for the most part, especially with steroids, like you don't want to just take it. It's almost I don't want to say like a last choice, but it is like we would have tried other things prior to giving this medications to the patients. So it is anti-inflammatory. That's the main thing that they work on, is the inflammation part. Um, what happens when you give it for a long time? You guys know some of the side effects?
Osteoporosis.
Osteoporosis is one of them because you have less absorption of the calcium. That's one of them. What's a telltale sign for prolonged use of steroids? Do you guys know? Think Selena Gomez. Moon phase.
Cushing.
Perfect. Yeah, Cushing's is one of them, and that's usually indicative. Like you'll see the moon phase. I should probably pull up the chat. There we go. So yeah, moon phase definitely is one of them. That's for like prolong, and you'll see that you'll literally start seeing their face kind of change in shape. Again, in my class, in my cohorts, I talked about how Selena Gomez ended up, having that because she has prolonged use of the steroids when she was getting it treated for lupus. So that's one of them. And then with this, they still have the same kind of like side effects or adverse effects as non-steroidals, like the NSAIDs, including the GI bleeding, the peptic ulcers. So what you wouldn't do with steroids, you're not going to take it together with some sort of NSAIDs. Okay, so you're not doing that. They might have some fluid retention and hypertension, so we would monitor them for that. And then for psych, they may have some mood changes, irritability. We do kind of recommend like the single day ones that they do take it in the morning because at night it can cause insomnia with this medication specifically. Okay. All right.
So prednisone specifically, it can cause insomnia.
Yeah. When taking that night, just because they get that burst, like their blood glucose goes up, and the actual medication's affecting your hormones. So what ends up happening is basically what your body does and how it naturally makes it is towards the morning time. So when we give it at night, we're giving it, when they should be awake, but they're not. You know what I mean? So
And then with
cool.
this one, it still causes the weight gain for the long term, right?
Say it again.
For this one, it still causes a weight gain for the
This
long
can cause weight gain, yes.
for long term and short term.
For long term, for short term, normally short terms, I'm thinking like a Medrol dose pack. You know how you just take it. Well, if you guys are not familiar with it, it's usually given in like a little kind of like a pill thing. You just pop it per day, But that's just a short term, like 7 day kind of treatment. Long term is like when they take it every day for a long time, like 3 months or more. And
Is
then
prednisone something that would be given for like COPD?
it can be a form that we do give with like the inflammation aspect of it, especially with like asthma per se, is it's called Solumedrol. It's really cool. Like it's I like the vial. It's a really pretty vial. But yeah, you just give it through the IV, that medication specifically, and it helps with the inflammation pretty quickly. Dexamethasone is also a medication we would give for inflammation that like in an ER setting. We might even give
I
dexamethasone
have
for
a
migraines as well. What's up?
sorry, I have a question. So I work in oncology, and I was always like wondering why they give like steroids for like when they're in chemo.
Mm-hmm.
Like I was just wondering like what it was for.
I mean,
If you ever made it.
I can't speak too much of like as far as like because we don't know exactly what the patients themselves have, but a lot of like oncology, like cancer patients, they may have some sort of inflammatory processes going on, and that's why they would give it. Chemo itself would already cause a lot of like side effect. It has side effects in itself, so as far as steroids, it might be just some sort of inflammatory process in their body that's going on during that time.
Oh, okay. Because yeah, sometimes like when I ask a lot of questions when we're at work, and like sometimes our kiddos have like really puffy like the moon face, and they're like,
Mhm.
oh, it's because they're on steroids. And I'm like, oh, like I wonder why. Like, and they're like, oh yeah, because like they need it for the chemo or something like that. So I was just wondering if you knew more, like you know.
Yeah. I mean, I've worked in oncology quite a bit actually. When I was working in Flowpool, they flowed me a lot over there. So I did work with a lot of patients who are in chemo, and I recall giving some, but yeah, it's probably due to some sort of inflammatory process. Because I mean, like, if they have a cancer or like a tumor that's growing, I mean, it might help fight it, but yeah, I could look into that a little bit more.
Okay, thank you.
Yeah.
Can you go into migraines a little bit? So
Let's
I
talk
have
about it.
the ABCs and the 10, but I um the way you explained it in class, I missed it and I didn't write it down, and it was different than the way it was explained in the book. So I wanted just to see it, not different, like the same, but I just understood it the way you said it.
Yeah. Okay, so when we think about like migraines, there's two different things that we can do for migraines, okay? When they're actively doing or when they're actively having a migraine attack, we'll have to treat that, right? Or we could give them something before they have migraine attacks. So the medications basically we give when they have acute migraine, so they're actively having it right now. Think about it's a 10. Remember we talked about that? It's a 10. So there's three different things that we would normally use to treat that. We talked about triptans in class. We talked about ergot alkaloids. Hold on.
So I know what they are. I just, as far as like memorization, I've got it, but the understanding. So triptan is just a medication, and then the ergo alkaloid is one that you give if the triptan doesn't work, and then the NSAIDs you would give on top of that. But then wouldn't somebody just, if they're having a migraine, why don't they just take an NSAID right away, like 2 ibuprofens or 3 ibuprofens or whatever?
No, they can, and honestly, that's probably going to be the first choice for them to take is the NSAID. Like when you have a migraine, you don't go, oh, let me get some sumatriptan. You know what I mean? Because those are most likely like prescription. But with the NSAIDs, like that would probably be their go-to, like go for. But this is just an easy way for you guys to remember how to treat them, like what to go, like the go-to to treat them. Okay.
Yeah,
The ergot alkaloid, the main medication is ergotamine. We talk about like, ergot migraine, right? As a way of
That's
remembering that. So when you guys are testing, you guys see ergotamine for migraines, that would be a choice for that. So basically what ergotamine does is it is basically it's a vasoconstrictor, and we kind of talked about this in class, I believe. And it helps kind of like narrow the blood vessels. So it helps decrease kind of like that migraine. When you have medications that's vasodilators, like we talked about nitro in class for chest pain, it dilates the vessel so we can have increased perfusion to all the organs. That can cause a migraine or a headache, and sometimes that's what we're looking for too when we're giving them nitro. Is like when they go, "Oh man, I have a headache." That's a big side effect because it dilates the vessel, so you're getting more blood flow into the brain more than like it needs, right? So that's what would cause the headache or migraine. So when we constrict that, we decrease that, and then it decreases the migraine as well. And then
Doesn't
the
that have
NSAIDs is the inflammation part of it. What's up?
doesn't that have other effects though, decreasing the blood flow to the brain?
Not necessarily, because like it's not. I mean, if you have like for a long time prolong anything, because the body kind of wants to have that hemo oh my gosh, I'm going like the hemostasis where it's just, everything's within its normal limits, right? So if you do it for a prolonged time, yes, there could be some side effects, but that's why we're able to give like ibuprofen because it has that wider therapeutic index that it takes a little bit while, like a lot for it to like cause that issue. You know what I mean? Same thing with ergotamine. We give them in safe doses. So, all right, someone has their hand raised.
Yeah, so I just wanted to ask, so for the trip 10, I can remember when you're talking about the stages of headache and the aura. So do we give a trip 10 when the aura, that's like when you suspect you have a migraine?
No, they'll have the migraine. The aura sometimes comes before the migraine. So triptan is actually treating it when they have it. So that it's a 10, that acronym that we gave you guys is when they're actively having a migraine. Like, hey, they have a migraine, we need to treat it. We would give them a triptan.
Okay.
Not before, none of that stuff. Now, all the before stuff, the prophylaxis, that's your ABCs. Do you guys remember us talking about that? Preventing a migraine. So this is for them to not get migraines before they even have it. For them to not have it, we give them these things.
So, but the ABC is an antidepressant. How does an antidepressant prevent migraine? And what does that even like, other than the vasoconstriction? But I don't even know antidepressants did that.
Let me look at my notes.
So it's antidepressants and anticonvulsants, and then beta blockers and calcium channel blockers.
So the beta blockers and calcium channel blockers, I can tell you guys right now, that helps with like blood pressure. So again, with like the constriction and stuff like that. So it helps with that. Hold on real quick. And search specifically. Okay, so if you think about what we do for people with migraines, let's say, have anyone here known anyone who had migraines? Right? So what do we want to do in the room when we put them in?
Lower the stimuli.
Ruin the stimuli. So the antidepressants and the anticonvulsants decreases that, the sensitivity. So we kind of lower that threshold. So that's how it helps with the migraines. Does that make sense? So it works, let's see. The antidepressants works in the central sensitization of the brain. So when everything is so like you have the higher stimulant, it helps decrease that. And the anticonvulsants, um, it helps calm down your brain. You know how like when seizures, those are the anticonvulsants, right? Your brain is firing. So again, this will help kind of calm down the brain so you have less of a migraine. So that's how it works, like centrally, like in your brain.
Is it common for these medications to be prescribed for medication or for migraines?
For migraines, it can be. I've seen it, and when you like look up a patient's charts, or like when you look up some of your patients and you see their like medical history and some of the medications they take, you might be like, that's weird, right? Like that's supposed to be for something else. There's multiple uses for some medications, and with the anticonvulsants and antidepressants, migraine is one of those like uses, right? I think I've talked to you guys about Benadryl a little bit and how it's normally used for, like if you have an allergy, right? But sometimes when we use it in the ER, we don't use it just for the allergy. We use it for like its antiemetic effects because now, like if they're vomiting because of a migraine, we'll sometimes give them the Benadryl, like IV. That'll help them with like the nausea part of it. So some medications have multiple uses.
I know the Benadryl has like there's a weird in weird cases it can actually be like a stimulant instead of like a drowsy medication. Is that something that we need to know
Do
for
you
the
remember that
exam?
word? Do you remember that
No,
word?
sir. I do not.
Idiosyncratic effect. That's part of your first PowerPoint slides for the first 2 weeks.
Okay.
It's idiosyncratic effect, and you should at least know that term, yeah.
Okay.
Team would be great. Okay, if I could find it, that'd be great. Okay. Yeah, you should know those terms. Let's see. Yeah, it seems like there's a lot of like definitions and things you guys have to know for this exam. So you guys need to know those terms. If you guys Did you guys all listen to the podcast?
It,
The
Yes.
podcast has a good layout of like your content outline and the concepts you guys need to know for the exam. That's why we made it. So it's good for you guys to listen to it. It is 57 minutes long, but you guys could listen to it to a car ride. You guys could listen to it, while you guys are doing stuff in your kitchen, you know what I mean? So we kind of made it that way, not that easy, but it has like a lot of information that would be kind of like seen in your exams, kind of like the concepts that you should know, okay? So
Can
Pharmaco can
you?
like go ahead.
Oh, I'm so sorry.
No, you can go.
Can you explain the types of pain we had in our slides? I knew you were talking about neuropathy being the worst one, but we were also arguing I think it was the midline, moderate, and the severe. Can you just break that down real quick on how to rate? I think it was like 4 or 5 of them.
You mean like the acute, chronic, mild, moderate? Yeah.
Yes.
So the only things that you need to know about this slide is just know that neuropathic pain is the least responsive to traditional pain medications that you guys are getting, like opioids or NSAIDs. Like neuropathic pain responds the least, so you can't really touch that neuropathic pain with just opioids or NSAIDs like you would do with everything else, right? As far as the medications, we talked about the adjuvants. So the adjuvant medications, like Gabapentin is the perfect one we normally use. That's what we would use to help in addition to some of these medications to help attack the pain because giving them even opioids, which are really strong pain medications that you would use for that, severe, right? The severe pain, you would use opioids. You're not going to use like NSAIDs for severe pain, right? But even that opioid is not going to affect or not going to touch the neuropathic pain because it's just the one that's least responsive, right? Now, for mild and moderate, you could use like the ibuprofen, the Tylenol. You could use that for those kind of pains. But in all honesty, if someone's having severe pain, perfect example, someone's in a car accident, broke the leg, we're not giving them Tylenol, okay? We're not giving them ibuprofen. We're going to give them something a little stronger. Does that make sense? Right. And then acute pain is anything like less than 3 months. So that could be from an injury, it could be something like short term, if you tweaked your back, stuff like that. Chronic pain is longer than that. So this is the group of people who would, probably would have some sort of pain regimen. And anytime they have that long-term pain regimen, honestly, there's a lot of studies that says like don't give them opioids just because it's not as effective. But you will see that a lot of your chronic pain patients will be on opioids for some reason, but they will also be tracked. So because they will give like 90 at a time of like Percocet or like 90 of, what I mean? That's a lot of medication, right? So they will have a time frame in which, they're expected to finish that. Um, and if they run out or if they lose it, they will have to get another prescription, and sometimes providers will not give it to them until it's time. So it kind of helps, like counter like overusage or dispensing it and stuff like that, like overdosing. Because some people like that feeling of euphoria, right? So yeah. Also know the basic stuff like people with diabetes, they might have the diabetic neuropathy or the neuropathic pain for diabetes. And like, you're still gonna do the same things you normally do. Check their feet. Like the foot care is very important because if they do step on like something sharp and it's embedded inside their feet, sometimes they can't feel that because of that nerve damage from the high glucose. Okay.
In regards to the pain, the adjuvant drugs, could you kind of go into the agonist and the antagonist? I can't say it. Oh my gosh.
No, you're
Um,
fine.
but it was kind of so do they work similar to the adjuvant drugs?
No, adjuvant, just think of it like it's adding to what you're already giving because what you're already giving is not working. So the
So,
agonist and antagonist that we're talking about, let's talk about like morphine in particular. So, or even opioids. So the agonist is like going basically it's an opioid agonist is like a morphine, right? So where it actually helps with the pain, it attaches to those pain receptors and it blocks it so you don't have pain. The antagonist is literally Narcan, which is the opposite of that, and basically it fights for those areas. So basically, um, those you think about it like a keyhole, right? So you have multiple keyholes that kind of like, hey, it's triggering pain. When you give opioids, you have the opioids, which is the key. You put it in there, it works, and it kind of like unlocks everything, so you don't have pain. The antagonist also fits in that keyhole, and it fights for that keyhole, right? And basically, it goes in that keyhole. Now the keys that's like trying to open it to release the pain to get rid of the pain can't fit because it's getting blocked by the antagonist.
Is
I don't
it
know if
like
that
the
makes sense.
chair? Is it like the
Huh?
chair analogy from the the chair analogy where like they're sitting down? Yeah, okay.
Yep. So now the opioid can't get on that chair because someone's already sitting on there,
Wait, can
right?
you tell us the chair analogy? I don't know it. Can you tell it?
It's on the podcast. But basically we talked about how there's if there's someone's on the chair and the agonist and antagonist. So basically if the antagonist is on that chair, like there's no room for the agonist to come in, right? So there's no room for morphine to come and relieve the pain because number one, they're probably over sedated from the opioid already. That's why we're giving them Narcan. So yeah, so they can't go onto that chair anymore because it's already taken, right? It's like it's the same thing with the keyhole. You can't put a key in a keyhole that already has a key in it. You know what I mean?
So is one
Uh,
stronger than the other?
Not stronger, but it fights for it. And the antagonist literally will reverse everything. Pull the key out and go in it themselves.
But then how come you need
Go ahead.
I'm confused. So are we talking about opioid antagonist and agonist, or are we talking about the adjuvant anxiolytics? Because I heard that, but then I heard the agonist and antagonist. So I'm kind of a little confused.
So we're talking about the opioids right now when it comes with the agonist and antagonist. We're talking about the opioids right now. The adjuvants, just think of it as just medications that adds to whatever we're treating them, so we could actually like get to that level where they get comfort. Does that make sense?
So it's like
Like
drugs that are already drugs, but they do a little more than the original drugs.
no, they just let me see, how would I describe this so it would be easy?
All right, I just got a little confused. We're
So
going in depth.
the adjuvant drugs, so basically what they do is they work with what you're already giving them to like help treat that pain. Does that make sense? It's
So
in
it's like the
addition to.
original drug just doing more than what the original drug would do.
I wouldn't say more, but differently.
Wait, I'm confused.
Okay, let me try
So
this.
you're adding to the original drug.
Yeah.
So the whatever's being added is doing something different than the original drug, but they're working together.
So basically, the adjuvant works in a different way to attack it. Okay, so you have nerve pain, right? So you have nerve pain, and you're giving them like opioids, and it's not working because it's nerve pain. So an adjuvant drug would be like we talked about the anticonvulsants and antidepressants for the migraines, right?
Mm-hmm.
So those adjuvant drugs works in the brain, a different part of the brain that helps, with that nerve pain because it helps calm down the brain. When you have nerve pain, your brain is shooting out signals like, hey, you have pain in this area. So the adjuvant drugs goes to your brain and it kind of says, hey, chill out, dude. And then like you won't have that much pain or it'll have a decrease in pain.
Okay, so just really quickly, and then you can move on. Long story short, what it does is it's like if I have a migraine and I'm not in the NSAIDs, like whatever, aren't working, they're gonna give me that like the sumatriptan or whatever that's
Mhm.
gonna help a different part of my body that's gonna in like the end help with the migraines.
Right. So like even sumatriptan is it's like a vasoconstrictor. So
Yeah.
the way it helps with decreasing your migraine is constricting your vessels as opposed to attacking your pain receptors.
Oh, okay. So
so
it just
Kate
helps with a different part of your body.
Hmm.
Okay.
Kaden? Am I saying your name right, Kaden?
Yeah.
So I think of adjuvant drugs like caffeine and sleep. So like when you sleep, like let's say like 6 hours, okay, you're still tired, you take caffeine, you're awake for a little while. But if you only sleep like an hour and you take caffeine, it's not gonna work.
Or
Does
not
that
as
make
good
sense,
because you
Professor
need sleep.
Cadaway?
Because you need sleep.
You
Yeah.
do need to. And 6 hours is enough, but I'm a mom,
Yeah.
so yeah.
So another one, you guys haven't learned about blood pressure medications yet, but the way kind of like another way of explaining it is like if they are taking like blood pressure medications, right? And then you give them a diuretic. The diuretic helps with the blood pressure because they're peeing out the excess fluids. So it helps a little bit. You know what I mean? It helps in that aspect. It's not directly attacking the blood pressure, but you're helping reduce it by peeing out all the extra fluids, right?
Yeah.
Which will
So
bring down the blood pressure.
yeah, so now that I think what confused like so then so like on the test, is it gonna have like a question? Like I know you can't tell us specifics, but like is it gonna be like worded like this person, like for example, migraines, let's just use that. But like this person has a migraine, it's now moderate to severe, typical NSAIDs aren't working, whatever. Like what we're gonna give them sumatriptan, what would this be considered? Would that be like the type of question, or is it gonna be
It
something
would
that
be
like
more
you have to know
like it would be
specifics?
more probably like they're either having acute or like preventative. What would you use to treat them? And it would give you a list of things to treat them. So you
But
need
why
to know TEN, like 10 for acute, and then your ABCs for prophylaxis. you guys need to understand this is your basics like intro to like pharmacology. So you don't have to go through the deep dive of like all of that at this point, right? So just know like basically all the things that we went over class. Um Again, I can't emphasize, but that podcast, I know that you guys feel like you don't have time. If you guys want to do well on the test, listen to that podcast and take notes. Go listen to the podcast and with your notes, just go over the stuff we're talking about. It could be a little silly sometimes. If you guys have listened to it, you know what I'm talking about. But it does have pertinent information that will help you guys kind of like have that thought process for this test. We're not doing things to kind of like waste your time and give you additional things because you guys have a lot of resources, right? Like I feel like we provide a lot of resources, so we don't want to give you guys additional things that's just going to waste your time. Like everything that we've been kind of giving you and like in class is to help you understand the concepts that you need to understand during the test and to be able to connect them. That's going to be on your part, right? To be able to connect those things. Alexis.
Okay, so in the PowerPoints, like every single slide, for example, like if I'm looking at the corticosteroid slide, it has
Yep.
like the prototype, prednisone, and then other examples, it's like prednisone, betamethasone, cortisone. Do
Mhm.
we have to, because there's like a long list of medications for
Right.
like a lot of the sites, do we need to know all of those like for this test?
So like what I would do honestly is like learn patterns. Because like even like let's say corticosteroids, right? I'm gonna pull where is it at? Corticosteroids. It has all these medications. You see there's a pattern of "-one" or
Mhm.
"-lone" at the end of it. So knowing that, you know it's a corticosteroid. So at least learn the patterns. The prototype is prednisone, meaning like that's the most common that you would see. So that might be the most common you would see on a test,
Okay.
right?
Um,
Because that's what
so
they know it as.
Sorry. So how would you suggest I mean, because you said you wanted us to move from just memorizing to actually understanding the med. Now, if we want to correlate like the corticosteroids and that long list of medications that we need to know that actually works in conjunction to what that steroid is actually giving us, like if we have like just from like looking at it and we have close to 6 or 7 meds that are doing the same thing,
Right?
and most times your last name is the last 3 letters of the name is not always the same, but they actually do the same thing. So how would you advise we actually know those meds so we can be able to answer questions on them effectively?
All I know is for me, whenever I took my pharmacology classes, I came up with really weird acronyms or like really weird ways to remember them, just so I could remember them. It doesn't have to make sense on how you remember them, but you do have to like know what they are, right? So the main thing with these ones is like, hey, if a patient is like taking two of the same classes, like they can't do that because you have an increased risk for all the side effects and adverse effects, right? So you need to know as a nurse and even as a nursing student, if it's on a test that says, hey, we have like this patient's taking this and this and this, and like you see two of them are the same class, like that's something that you would like talk to the doctor about. That's something that you would want to stop because it increases it, you know what I mean? It increases the risk for all the side effects. So that's the reason why we have all these names down, is because you guys need to know that, like, hey, if someone's taking Aleve or naproxen and they're taking ibuprofen, like there's something wrong, right? So that's going to be like a flag for you guys. And seeing the words and memorizing some of these like names, when you see them as a key term on the test, you know what they're asking about. So when they say, oh, this patient is taking methylprednisolone, right? Like what are some nursing considerations or what are some things to talk about when they're taking it long term and stuff? Well, now you could link it to a corticosteroid and then you could think about all the long term stuff, like the Cushing syndrome with the moon phase and weight gain and increased blood sugar and all that stuff because it's all connected. Does that make sense?
Is the
I
stuff
know
that
I told you guys more about like connecting them and learning in that aspect, but like we also need to know what it is, right?
But for right now, do we need to know that depth? All that in that depth, like that, like the grapefruit juice and how it inhibits the absorption of some medications, or not inhibits,
Honestly,
what's the other word?
honestly, if it's like contraindication and grapefruit juice is there, pick it. Because grapefruit juice is like anti everything, right? But what I would want you guys to know, the reason why I kind of want you to learn it that way is because it's free game when they ask about side effects. It's free game when they talk about like, what this medication does or the contraindications. That's literally like gonna be on your exams. On these ones, I don't have the questions in particular, but I have the concepts of what you guys need to know. And I mean, yeah, no, I don't have any questions. Like I don't really take the questions. So, but as far as the concepts and what you need to know, you guys need to know them. Like you need to know the side effects. And then some of them are specific side effects. Like, the moon phase is not gonna go with NSAIDs. You know what I mean? So you guys need to know those ones, right?
Yeah, I thought Moonface went with corticosteroids.
Right. So when they talk about moon phase as an option for, let's say, an NSAID, you're not gonna pick moon phase.
I'm not, or I am.
You're not because it's not for
Oh,
NSAIDs.
yeah, sorry, I just couldn't hear you correctly.
No. It's for steroids, right? So to know that stuff, but they also a lot of them also share the same thing. So that's free for like the all that all can or select all that apply. It's also like GI bleed. It's for corticosteroids and NSAIDs, right? So sometimes they kind of overlap.
Is there, or I think somebody else had something. I had a question for you, but after them, I wanted to see if you could cover something else. It's in the chat.
Yeah, someone said how many
Concepts.
med math? Someone said 5. What concepts did you want to go over, Alexis?
Sorry, I thought you were given like, wait, let me think about this. You said you weren't given the questions, but you said you were given like specific concepts that we had to go over. I was wondering if maybe like if those concepts were just correlated to what we were given on the study guide, or if you have something different.
So honestly, like if you guys can create your own study guide based off of like the content outline, like there's a lot of things to know here, but there's like pretty simple things that you should know, right? Like pharmacodynamics, pharmacokinetics, how pharmacology is used, classification of drugs. You guys should know about generic names and trade names, right? So these are like definitions that you guys should know. You remember ADME from the first PowerPoint? You guys should know that, right? You guys should probably know what first pass is with the liver. You remember that?
Yes.
Yes.
We've talked about it. You guys have brought it up in my cohorts. They brought it up in class. So you guys should probably know what first pass is with the liver. It's like a toll booth, right? So the liver kind of like consumes, so it's not going to be as effective as giving it via IV. It goes straight to your bloodstream, right? When you take PO, it's not going to be as like effective because it does that first pass, and the liver takes a little toll. Like, hey, give me some of that before we release it to their bloodstream. So the bioavailability of like an IV medication is way more, right? And then administration, you guys know about foods, how it they have interactions with foods and drinks and signs and symptoms. Make sure that you're checking labs for certain medications.
What are the labs? I had that on there as well. So in the podcast, you covered some specific. Sorry, I have 3 study guides open. Let me find
You're
the
fine.
not that one. Or they're not all study guides, but I have a lot of things open too. Okay. So you emphasize the ALT is a liver function test. But then in regarding one of the other, where did it go?
We talked about CMP and BMP to check the kidney functions. Remember that one?
That's what it was. Yes.
So anytime you see BUN or creatinine, that is kidney.
Okay, right. Oh, that's literally renal function lab values. So creatinine and BUN are for the and then with liver disease, that's the ALT, right?
Yep. And
Okay.
ALT and AST, yes.
And AST, and then And then are those specific, or do they usually come with like a full panel? Like,
So the liver panel, those are the main two things that we look at as nurses, honestly. If it's elevated, there's something wrong with their liver. And then like even with that, like you guys need to know like, hey, if their liver is compromised, how does that affect the drugs? Right? If they're older they're aging, they're older population, how does that affect the drugs? Like the medications we give them, right?
So
They
that
have
And that,
Go ahead.
is somebody else saying? Oh, go ahead.
Colleen, were you singing?
No, I can't sing. I was just gonna say it just means they're not being properly metabolized.
Right. And what does that mean to the body? Like, what does it do? What does it do to the drugs in the body?
Toxicity.
Right. You have increased toxicity. Same thing with the older adults. Their liver is not working as good. Their kidney is not working as good. So we may need to give them a lower dose because of the toxicity, right? The medication staying in their system longer. So with that toxicity, that's why we talk about the therapeutic index. When they get to toxicity, they have a higher chance of getting side effects. Yes.
Okay, so good. I was just gonna talk to you about the therapeutic index, and I know between we need to know the concentrations when it's like minimal and when it's at its little level, right? For a question, would they give us those records, or we have to know? I mean, for let's say, for example, the creatine level as to what's gonna damage the liver, are we gonna have like a chart where we can actually read and answer a question like that?
You guys aren't going to be looking at charts like that. So
Okay.
the what you need to know about therapeutic indexes is wide and narrow, what they are. So wide is like over-the-counter medications. You need to know that they're generally safe. Probably
Okay.
doesn't need a prescription. Narrow, they will need a
They
prescription.
don't need a
They will
prescription.
probably need blood work because you need increased monitoring.
Yeah.
So like
That's the only thing. It's not as in depth as you guys are.
Okay.
I know you guys are kind of like scared and stuff, but like like it's not going to be that in depth as far as that goes. But to at least know the terms, what they are, what they stand for, right?
So for the one with the wider, that doesn't have a narrow, that's like the over the counter medications, while the prescriptions are like the prescriptions are with the ones with the narrow,
Yeah.
okay.
And you know what the therapeutic index is, right? Do you guys
Yes,
understand what it
yes.
is?
Uh-huh.
So it's the pretty much the space in which the drug actually works in the body. It's therapeutic. So let's take Tylenol, for example. It's wide, right? If you take 500 milligrams of Tylenol, sometimes it's enough to take away the headache. Sometimes you have to take 1,000, right? 1,000 milligrams or 1 gram of Tylenol to take away the headache. But if you take 500 or 1,000, it's pretty wide, that dosage range, but it can, it's still safe to take to treat that headache, right? That's why it's wide, the therapeutic index and the level at which it works, like it's pretty big. But if you take like blood thinners, for example, if you give them a little bit more than what you're supposed to do, they have a bigger risk for bleeding. If you don't give them enough, they're gonna clot, and then we're not doing anything for them. They might as well not be taking it. You know what I mean? That's why it's narrow, because we need to give them the right amount. And like warfarin or Coumadin is one of those medications. You don't need to know that right now, but it's a narrow one because we have to do blood work all the time and monitor if it's working or not, if they're in that safe level or not. Because if they're not in that safe level, if they're under, guess what? We're going to up it because we have to, because it's not working. They're going to clot, they're going to have another stroke, they're going to have another heart attack, whatever. You know what I mean? Or if it's too much, it's like, oh, they have a huge risk of like bleeding. They can start pooping tarry stools, or like, and you don't even know because it's happening. It might be happening inside of them. You know what I mean? Or they have a higher risk for like hemorrhagic stroke if they fell, like all these things. So we want to keep it narrow. But the wide one is like we could give them, it's pretty safe. Like you don't even need a prescription mostly for the wide ones, right? You guys need to know prototypes and examples of prototypes. We talked about that a lot.
Can you give us an example right now? Because my mind went blank when you said prototypes.
And said the main one that they give in class that we gave in class was aspirin, right? Most of you guys use ibuprofen over aspirin, but aspirin is the prototype. For opioids, morphine is the prototype.
So just like the name of the most common drug used in that class.
Yes, ma'am.
Okay.
That's literally what it is.
What
Mhm.
about nephrotoxic meds? Do we need to know any like what medications would be nephrotoxic, or do we just need to know the definition?
Just know the definition that it harms the kidneys, right? Um, like NSAIDs long term would be nephrotoxic, not necessarily when it's short term, but like if you use it, that's why when you realize that it can be nephrotoxic, what to look out for as far as side effects, right? So that's the main thing that you guys need to know is like some of these medications have similar side effects. Know the early and late. Like early would be all the regular stuff, the DIY, nausea, vomiting, diarrhea, things that you could treat yourself, right? And then the more severe ones are more specific to the medication.
Could you cover kind of how they would treat like opioid withdrawal or opioid addiction? So I have so oxycodone is an opioid, and so I'm thinking more in like methadone, buprenorphine,
Yep.
and then how somebody could become addicted to one of those,
Mhm.
and then like the medication assist, like how those are used and how like what nursing considerations are for those type of meds.
In all honesty, the fact that you know that it's methadone and buprenorphine, I feel like that's more than enough for that section. The fact that you know that because the methadone and the buprenorphine doesn't have the same euphoric effect as the other medications, and methadone specifically has a longer like half-life, so they don't have to take it as often. But what it does, it takes away their cravings when they are addicted to opioids like morphine or oxycodone. It takes away that like the edge and like the where they feel like, oh man, I need something. It takes that edge away without the high, without giving them the high. Does that make sense?
Yeah.
Yeah. And your ATI
And
actually took well, I took the ATI for seventh semester, and that was one of the questions was like, and it was very simple, like, hey, out of all these drugs, which one would help like with facilitate like, you know, like treatment for someone who's withdrawing from opioids, and like methadone was one of the you know what I mean? So it's like,
so I just wanted to confirm something. So for the opioid antagonist, right? You said when we use let's say for example you use Narcan, right? And when you use Narcan, it takes away the high at the moment, but they still get their withdrawals and the pain, right?
so you're literally gonna bring them, you're gonna reverse everything with Narcan. Their pain comes back, and it's almost like a fight or flight. If you guys were in my cohort, I talked about fight or
Mm-hmm.
flight a little bit as a
Mm-hmm.
review, but they have the same like symptoms as fight or flight when you give them the Narcan. So like when they're overdosing, remember their eyes are pinpoint when they're
Yes.
overdosing from opioids. When you
Mm-hmm.
give them the Narcan, it'll dilate, like
Yeah.
the bronchioles will dilate, their heart rate will go up. They might have a spurt in the glucose, like it's all the fight or flight thing, right? Um, so just keep that in mind.
So
Like I
it's
said, my patients came out swinging, so
yeah. So it's more of like bringing them back to reality than they feel everything they felt before the high.
right. So if they had pain, they were taking it because they had a lot of pain.
Okay.
Some of the pain will come back.
Okay.
Yeah. But what are we worried about, or what are we doing after we give the Narcan though? That's important. It's important for you guys to know. When we give them the Narcan, what are we doing with the patient?
Monitor.
For how long?
Monitoring
Their breath
read the respiratory rate.
For how
Mhm.
long?
for two
Uh,
hours or over 2 hours.
Is it 2 hours?
over
Okay.
Yeah.
Okay.
2 hours. And what's the reason for that?
Is it
Just
the vital?
because
Because the
Huh?
half life of
the
narc.
opioid isn't the opioid like a respiratory opioid it depresses, I mean it's respiratory depressant. So when we give Narcan, we want to make sure we're monitoring the respiratory rate, right?
In case what?
Yes, sir.
For
Huh?
like respiratory suppression.
So
I don't know if I said that right.
Depression.
Depression.
I
So
mean does
basically,
if
they
I was
So
close.
they
sorry.
could be sedate, guys. They can go back. So the half-life, we talked about half-life. You guys need to know what half-life is, but the half-life of Narcan is a lot less than like the opioids, right? So opioids, a lot of them 2 to 4 hours. The half-life of Narcan is like 90 minutes. So it's a lot less. So they have a risk of getting sedated and being overdosed again, like getting all those everything that we were preventing, they could do that again if we don't monitor them. And if they do that again, what do we do? If they
So
start
we
having the respiratory
More.
depression, what do we do?
do we
Another
give
dose
them
of
more?
Narcan.
We get more.
You give them more.
Yep.
Okay.
And then we
And
get
then you
more.
monitor them again for 2 hours. You know what I mean? So that's really important for you guys to know. Yeah.
Do we have
So
to know?
is
Oh.
there, I don't know if this is gonna be part of the exam, but could there be like a little dose for Narcan? Because if you're saying if the half-life is 90 minutes.
Don't worry about that.
Oh, okay, okay.
Lethal dose, we usually don't give Narcan more than like 2 or 3 times like that, but like it's not like a lethal, like, I mean, obviously if you give someone way too many, anyone could die of anything, right? Tylenol would be an example, the worst way to die, right, with the overdose. But yeah, for the most part, when we do give Narcan, it's usually with like an order of some sort. If like lay people, like people in the community are giving Narcan because we have the whatever, the it's out in the public now to help, then we would tell them to go to the ER and then we would monitor them as the medical professionals. Alexis, you were gonna say something?
We don't have to know the half-lives of all the medications, right? I don't
You just know what it is. You just know what half-life is
what it
and how
is,
it
but not
affects the
how long.
body. Yeah, because
Okay.
honestly, half-life, by the time half of it is like gone, the therapeutic effect or the way it works is gonna be gone also. Like it's no longer gonna be working in the system. Blood pressure medications are like that. If their half-life is 12 hours, you would have to give them another pill 12 hours later. And half-life determines how often and the dose that we give patients.
So just know what it is. We don't have to know the exact numbers right now.
Yeah. Not right now, no. But I mean, I've talked about morphine, how its half-life is 2 to 4 hours every time. I've talked about Narcan, how its half-life is 90 minutes. So you should probably take note of those things. But
Yeah.
yeah, like
Okay.
every medication has different half-lives, and you guys have your drug books to refer to when it comes to that, okay?
Thank you.
What about the drug interactions? Do we need to know about those? Obviously, you don't take one NSAID with another NSAID like aspirin and ibuprofen.
Mhm.
But is there any other ones that we need to know, like good and bad?
Yeah, I mean, we talked about like herbs too, right? Like ginkgo biloba, garlic, all the G's, like has a tendency to bleeding. So you might be wary of giving those with NSAIDs or anything else that causes bleeding, right? Aspirin,
What does
anything else.
garlic have to do with bleeding?
Garlic is just an herb that can like basically it helps with like circulation. Give me a second. It's not like a big thing, but I think in addition to it, but basically it's also with the platelet aggregation. So it's the same. It kind of does the same thing that aspirin does with the platelets. It makes them a little bit more slippery, like soap, so they don't stick together, so they can't form clots. So that's why they have increase in bleeding with the garlic. So yeah, and there's a lot of different herbs out there, but our rule of thumb is like anything G. It's like, oh, that might be for bleeding, right? Ginkgo biloba, people use it for memory. That can also affect it, but just know that it might be, if you might not want to give it with blood thinners or NSAIDs, okay? You guys know about black box warnings? It doesn't mean don't give it. It just means that there's a lot of complication that can be with it. You know what I mean? All right. Contraindications, why you wouldn't give a drug, other drugs that can't be given with it. We talked about that.
What
Beverages
about
that wouldn't be.
CAMs?
Cams?
And then distractions as well. It says do not use with somebody who has cognitive issues.
Oh yeah. Because why would you do what was it, the guided imagery with someone who has cognitive issues? They're not gonna be able to follow you. You know what I mean? But cams is like let's say you sprain your ankle. You're not gonna go to morphine right away, right? You're gonna be like, hey, maybe I need to maybe I could put ice on it. That's a cam, right? It's an alternative treatment. Maybe I could elevate it, people with pain, sometimes music therapy helps, distraction helps, stuff like that. You know what I mean? That's why someone playing video game could not realize they're in pain because they're so distracted with the video game. And then they stop and all of a sudden it's like, oh, my ankle does really hurt. You know what I mean? So those would be like cams.
So in relation, kind of off topic a little bit, but like so when kids are super distracted and they're like not in pain at all, and then all of a sudden like you turn off their TV, it's like, oh, I'm dying. I'm actually in a lot of pain. So that's real.
That could be real, in all honesty. Another one would be like, you know how kids get constipation sometimes?
Mhm.
When they're playing, they kind of like suppress or forget the urge when they're pooping. Like their body's like, hey, we need to poop right now. And they're like, no, I'd rather play. So they like suppress that urge to poop. It's kind of like that. They're distracted and like instead, and then they get constipated because they don't want to poop, you know? And then all of a sudden they're like, I really need to go. And then they try to go, but they're constipated. And then you have all those issues after that. But yeah, it's kind of like that. It's just distraction, right? Um, there's a list of definition on your content outline that you guys should definitely know. You should know this because these are common terms that nurses use, and you should know the difference, right? We talked about side effects already, kind of like your DIY, and then your adverse effects are the ones that you would need help on, like some sort of maybe doctor or someone would write something else to help you with that. Contraindication, like you shouldn't give it, right? Um, what you would educate your patients is basically what I educate you guys on and everything in class and also in that podcast. I can't say podcast enough, guys. But you know what I mean? Like just know those, okay? Um,
Can you touch on injections really quick? So, if it's less than 1 ml, um, but on the somewhere, I don't know if it was Google or if it was like, but it said it could go up to 2 mLs for your deltoid. So then would you just do like 1 and 1? But on the podcast it said strictly 1 ml.
so for me, anything above 1 ml, I give in the ventral gluteal
Okay.
if they're an adult, you know? And ventral gluteal, the way you guys remember that is very good. Very good. Ventral gluteal.
And then
You do?
dorsal is danger, right?
Yeah, dorsal is danger because why?
Nerve pain?
Yeah, it's like
The sciatic nerve. The sciatic nerve.
The sciatic nerve.
But it is nerve pain, yes. And in the podcast,
It's good, guys.
yeah,
It took me 6 hours to get
Professor,
through it, but it's good.
I watched
Professor
it.
Amador talked about her experience with nerve pain when they gave it to her dorsal gluteal, and it's not pretty. So she experienced it, and she shares a little bit about it in the podcast. But yeah. Mm, mechanism of action, you guys should know that term at least. It's just what the drug does in the body, the journey of the pill, right? That's the mechanism of action. So yeah, you guys have a lot more content outlined on the first week than the second module. You see. Yeah. Oh, gout. Oh, gout. Do you guys know anything about gout?
It's an infection.
No.
I blinked.
Is it not?
No.
What is it?
What is it? I'm trying to find it.
What
I
kind
think
of-
it was
I think there were some questions on the ATI, the one we did last on gout. That's why I'm like trying to think about it.
So gout
Oh,
is
it is.
basically
Oh, that's
Yes,
the
it is.
crystals.
It is the crystal.
Oh.
Come on, I couldn't.
the needles. They look like needles if you look up under a
Yeah.
microscope. They look like needles, but yeah, so basically it's just a buildup of uric acid in the system, and what it attacks is the joints, so arthritic. Any joint.
There's
So
a
your
medication
feet, your
that's
ankle,
given with it.
yeah,
for it.
colchicine.
Wait, is that the generic name? Because we had a couple scenarios in one of the exams. Is it
Yeah. Allopurinol is the prophylactic preventative part, but when you're having an active attack, um, colchicine is the medication, and also endomethacin, which is an NSAID. It's in your list of NSAIDs, but endomethacin works the best for gout. I could
What
attest.
was it? Say it again.
Endomethacin or indocin, it's an NSAID, but it works for gout. It's
Spell that.
awesome.
Spell that.
INDO,
Mm-hmm.
methacin, METHACINE.
Yeah. Thank you.
No, but it's awesome. I love it. I know how to treat gout because I get it once in a while because I eat bad. But yeah, so if you guys have any questions about gout, I'm the master. Let me know. Um,
Oh, freaking,
you guys know about antipyretics. And honestly, when you guys are reading the questions on your exam, read the keywords, and then really think about it. Don't if you don't know the answer right away, like don't just be like, oh well, I have to guess and just start freaking out. Like try to work it out in your brain. Like, hey, you're asking for this. Like, what would I do as a nurse? And then go from there, right? Just read the keywords and read it carefully and see if you can answer it before even looking at the answers. A lot of students I've noticed will go back and change their answers and then get it wrong after they change it. So just make sure you read it, and then I think you guys are going to do really well, honestly. Yeah.
How in depth? So for specialized populations, is there something? Oh, so teratonic drug. How much in depth do we need to know about that? I don't know if I said it right.
Teratogenic.
Ter-
Just
Tinnitus?
know
Tinnitus?
teratogenic drugs. Just know that it affects the fetus.
Okay, and that's it from there.
It crosses the blood-brain barrier. It affects the fetus. The word that they use. What was the word that Professor Moreni said? Fetal dismemberment. I think that's what she used.
That's so
It's a
scary.
terrible word for teratogenic medications, but yes.
Okay.
Yeah.
And then so with older adult consideration, it start low and go slow. So start with like a lower dose. Is that like a generalization for every med?
Yes. So the doctors obviously will order the medication, so they'll take the consideration. But the reason for that is again the toxicity. But yeah, you would just start low, and go slow. Yeah. So we would give them instead of like, let's say me, I feel like I'm fairly healthy and young. They would give me 4 of morphine. For an adult, they would give them maybe 1 or maybe 2 of morphine, right? So it's very low, like a lower dose. You're muted.
It wasn't. I was talking to my kid. Sorry.
Oh yeah, you good. But yeah,
Well,
so
so if pediatrics, adolescent,
Hi.
I not right now. Oh, look at that.
hi.
Oh, look, Arlene said hi too. You remember Arlene? Okay, bye. Go. So toddlers, accidental poisoning, delayed speech. What about like in regard to delayed speech and motor development? What are nursing considerations for the groups?
So just
The
know
spe-
those, the things that you just said, that group is more prone to like delayed speech or motor, whatever you said. That group, right? For the adult, the older adults, like the elderly population, they're more prone to toxicity, stuff like that. So that's what you need to know. It's not too in depth when it's that. Like I know you guys want to go deeper, but like, yeah, this is your first intro to like Pharm. So it's a lot of it, not gonna lie. I want you to connect those concepts, but you do have to memorize a few things because you don't know them. You know, you don't know some words, you don't know medications. So that's the reason why we need you to memorize a few things too, in addition to learning concepts, but you do have to know them. Because there's gonna be times where you know, when if you want to review your test or whatever, like where we're going to tell you the concepts that you're missing, and a lot of it's just memorization. There's some things that you do have to memorize. The terms on the module 1 outline, we need to memorize those terms. Like, what are they? We at least know what they are, right? If you don't know what metabolism is, this test is not going to be very friendly to you, if you don't know what excretion is and like, absorption or even distribution, the first pass or half-life, if you don't know those terms, like it's not gonna be good because you're not gonna understand the concept of what pharmacology is, because these are kind of like the core introduction terms that we need to know at least, right?
Is it always 70% what the liver takes during the first pass? Like, is that the standard that we should know?
Just know that it's like a toll booth. Just know that it does take some medications, which affects the viability with the distribution and how much the body can use, because it does take its own toll. It just depends on how the liver is working too, because it might not be able to. You know what I mean?
Okay.
Yep. Peak onset, you guys need to know that. Talked about interactions. All right. All right. Does anyone else have anything? You guys will be happy if you listen to the podcast, I'm telling you. Patricia, you said you listened to it, right? Was it
Yeah, I listened
informative?
to it twice and I made a whole study guide. And like I used the transcripts and everything on, but it's just the way that you guys worded it because it was like you were talking to us, not necessarily I mean, you were teaching because we were learning, but it's yeah, especially the transcript part of YouTube, like it's not 100% accurate, but I paused. It literally took me like 6 hours on Sunday.
That's funny. You could take remember when I talked to you guys about like using different tools? Like I know there's some places where you could actually upload the video and it could like do the transcript for you or like, so it'll save you some time. 6 hours is a lot, but you probably learned a lot during that time. But yeah, there's some tools that you could actually upload the video and it'll help kind of like organize everything. So but yeah, watch it. You guys got this. Just read the questions, read the keywords. If you guys have any questions, you guys could sign up to meet up with any of your instructors, whatever our availability is. But I'm more than happy to meet up with anyone in my cohort. So just sign up and then think we're good. You guys are good?
Bye. Thank you.
Okay. Bye guys. Have a good night.
Bye. Good night.
Thank you.
All right. Bye.